Debates is Maria BERROCAL and Jay Sheth. I'm going to invite my good friend Maria BERROCAL. First line treatment for proliferative diabetic retinopathy, laser. Maria?
Thank you, Lite. And thank you so much for having me here. It is a distinct pleasure to be in India at this meeting. So laser PRP. We know laser PRP stands the test of time. The DRS way back from 1972 to 75 showed that it reduces the risk of severe visual loss by over 50%. It is cost efficient, has minimal devastating complications. It stabilizes the eyes long term. Most eyes stay stable for more than 10 years after initial stability. Compliance with treatment is not required. If they get lost to follow-up, tragic things do not happen. And it has a very reduced treatment burden. So let's look at complications. Complications of laser include visual field reduction, nyctalopia, can cause some fibrosis. But complications of anti-VEGF injections include visual field reduction also because the visual field reductions, as was shown in Protocol S, has to do with the degree of ischemia, not necessarily the laser. Endophthalmitis, retinal detachment, cataract formation, uveitis and vasculitis, and severe fibrosis. But if the patients are lost to follow-up, and this was published by Obeid in 2018, when patients were lost to follow-up, if they were treated with laser, 2% of those eyes developed traction retinal detachment. But if they were treated with anti-VEGF, 1/3, 33% of those eyes developed a traction retinal detachment, many of them inoperable. They also develop rubiosis and neovascular glaucoma. And we know that patients, diabetic patients, are lost to follow-up between 25 and 50% of them just don't come to appointments. So everybody talks that Protocol S showed similar changes in visual acuity between laser and anti-VEGF, and that we should use anti-VEGFs. So let's look at Protocol S, the 5-year results. In the laser arm, the average number of injections needed, because patients were injected if they had macular edema, were 5. In the anti-VEGF group, it was 19. The mean number of visits was twice as many in the anti-VEGF. They had to come in back if they had complications or et cetera. And even in the anti-VEGF group, 14% required PRP laser. Similar numbers developed vitreous hemorrhage, 46% in the PRP laser group and 48% in the ones treated with anti-VEGF. But this is very interesting, something we don't talk about enough. Cardiac disorders happened in almost twice as many of the patients treated with anti-VEGF. Cardiac deaths in 3 times as many patients in the anti-VEGF group. Total deaths in twice as many patients, and neovascular glaucoma in about the same. So let's think about what happens when you're lost to follow-up. As I said, eyes lost to follow-up do worse if they're only treated with anti-VEGFs. 33% develop traction retinal detachment versus only 2% in the ones treated with PVR. And some come in, like the one on the right, with neovascular glaucoma and lost eyes. And when we inject anti-VEGFs in patients that have a partially attached hyaloid, like this patient, they can develop the crunch effect and a traction rhegmatogenous detachment. You see the same thing in the left. After a mild vitreous hemorrhage treated with anti-VEGF, developed a traction detachment and a traction and rhegmatogenous detachment in another patient in the right. And why does this happen? Well, now we have information that anti-VEGFs cause fibrosis. They cause the angiofibrotic switch, which leads to fibrosis and traction retinal detachment, especially when lost to follow-up. When we look at the Yosemite and Rhine data, comparing aflibercept with faricimab, we saw that in the aflibercept arm, 8% at only 2 years developed epiretinal membrane. So fibrosis happens after anti-VEGF treatment. And let's talk about endophthalmitis, because we all say, oh, endophthalmitis, the rate is so low, it's only 0.01% to 0.26% per, but that is per injection. And we know that diabetic patients have a higher incidence of endophthalmitis. And when we look at, if we were to treat these patients as per Protocol S, the rate of endophthalmitis per eye would be between 0.2% to 5%, considering the 19 injections. So this is not a small risk. And let's talk about the treatment burden. Okay, PRP, most eyes are stabilized with a full PRP, which can be done between 1 and 3 sessions. But anti-VEGFs, we have to keep in mind, it does not reverse neovascularization, it masks it. If you stop the anti-VEGF, the same neovascular vessels come back. It only suppresses the VEGF for 1 to 2 months, and the ischemic areas remain. So you need continuous treatment almost for life. And when we think about the 19 injections in 5 years for Protocol S, and the 43 visits in 5 years, it's twice as many visits as the PRP arm, even within a study. So let's think about treatment burden. Let's talk about the US, the world's richest country. In the US, 25% of all health dollars are used to treat diabetes, complications of diabetes. That's a quarter of the whole, and it has the costliest health system in the world. The US has 34 million diabetics diagnosed, 10 million with diabetic retinopathy, 2 million with vision-threatening diabetic retinopathy. That would mean over 1 million with proliferative diabetic retinopathy. If we are going to assume they're going to get 19 injections in 5 years, that would be 19 million injections. That's 3.8 million injections yearly. At a cost, averaging the average cost in the US of the visit plus the drug, et cetera, it's about $700. So that would be $2.6 billion a year just for treating proliferative diabetic retinopathy, not including macular edema, et cetera. So PRP treatment, assuming putting a cost of a PRP at $700, it would only be $700 million if we were to treat them all with laser. So cost of anti-VEGF is more than 4 times the cost of PRP in the first year only. And in the patients treated with anti-VEGF, it is a recurrent cost. But let's talk about India. We're in India. India has 180 million diabetics. The prevalence has tripled in the last decade, as in many developing countries. 7.2...
Maria, can you sum up?
Yes, yes. So when we look at this, we would need to treat patients with PDR over 9 million anti-VEGF injections yearly. That would be 760,000 injections monthly. So this is enough to just bankrupt any health system. The burden of the patient and the burden to the health system is simply unsustainable. Thank you.